Hello there, Tony Meekum again, your favorite oral and maxillofacial radiologist. This is topic 7, well-defined radiolucencies with internal calcifications. So you know the drill, get your study guide out and keep your differential diagnosis chart handy. This is the outline, also the acronym to help you remember the lesions that belong on this differential, CACAO, for calcifying odontogenic cyst, adenomatoid, odontogenic tumor, calcifying epithelial odontogenic tumor, Ameloblastic, fibro-odontoma, and then the O is for osseous dysplasia, which we've already covered, so I'm not going to cover it again in this lecture, but it does make a nice round acronym. So the CACAO, also the background you see here, should help you remember that this has to do with radiolucencies with small calcifications. And so I just wanted to point that out on your differential diagnosis chart. Here we are. I know that's pretty small. Let me zoom in a little bit. But where is that CACAO? If you go down here to calcifications, just down a little bit to the left. So everything I teach here is going to follow this differential diagnosis guide. And when you see something in clinic or see something in one of my lectures, go to this guide and hopefully it'll help you remember these things that you've learned about in this course. All right, so this is our first one, calcifying odontogenic cyst, or COC. I kind of consider this one the bimodal distribution lesion. And what do I mean by bimodal distribution? If you're not sure what that is, that's kind of like this chart here. Test scores by students who attend live sessions versus students who don't attend. And I would also add, it really correlates with those who study my quizzes very well and those that don't. So study, do well, don't study, fail. You can see there are a couple of synonyms here. I don't usually use those. I usually just call it the COC, or calcifying odontogenic cyst. All right, so what exactly do I mean when I say this is the bimodal distribution tumor? Well, here's one thing in yellow text here. First of all, the age distribution is bimodal. The first peak is between 10 and 19, so the teen years, and then the second peak is fairly old, the sixth decade, meaning in the 60s. And so the average would be somewhere in the middle, but that's not actually a very common age for this lesion. It's more common in younger or older. And everything else behaves like a typical cyst. This has some properties of a solid tumor. In fact, the World Health Organization used to classify it as a tumor, if you notice the name here, but we're back to calling it a cyst. And this is the second thing I mean by bimodal tumor, if that's the distribution of location. Notice that it is rare. I said most tumors and cysts, they all tend to occur in the posterior mandible. This one occurs in the anterior, and it's kind of an even split between the maxillary and the mandibular, maybe a little bit more in the maxilla. And so both the age and the distribution of location vary in this lesion. All right, in most cases, this is going to be well-defined, corticated, round, like you would expect for most cysts. There may be some variation in that, but this is in this lecture because it causes foci of calcified material, whether that's white flecks, small smooth pebbles, or even larger solid amorphous masses. Rarely is it going to appear multilocular. That happens more with the CEOT, which we'll cover in a minute here. And so what's the big thing for this? This is the bimodal one. It's a somewhat rare tumor, but maybe you get a young patient in the anterior, you'll have this as well as AOT, especially if it's a female, or if it's an older patient in the anterior, something that causes calcification. So here are a few examples of that. A COC on the lateral incisor. You can see this impacted lateral incisor here. You can hopefully appreciate the nice, smooth, well-defined, round, corticated borders. And of course, the internal calcifications. They look somewhat dystrophic, maybe kind of a fibro-osseous appearance, kind of a ground glass appearance. All of these cysts and tumors we're going to talk about in this lecture, they really vary in the type of calcifications they have. And each of them can create maybe these pebble-like or the flake-like. And so it does vary the type of calcification. And then over here on our right, image C, this is an axial slice of a CT. Hopefully you can appreciate that these are the maxillary sinuses. And obviously there's something going on here. It's got some borders around it. This arrow is indicating the border, showing that here's still some sinus, right? Sinuses should be filled with air. They should be black like this. But in this case, we have the border of a lesion. It's nice and well-defined and corticated. And then we also see some calcifications along the posterior border. So that happened to be a COC. Another example, this time not in the anterior, but not everything reads the book. And so we still have a well-defined corticated lesion. Fairly young patient, right? Third molar is still not erupted. Some resorption of the root here. But based on the age, we might be thinking COC, among maybe some other things. All right, differential diagnosis. Obviously, if it's involved with an impacted tooth crown, think of dentigerous cyst, especially if there's no calcifications. Other lesions that cause calcifications we're going to cover in the rest of this. Specifically like that last one, in the posterior, think Ameloblastic fibro-odontoma. So we'll get to all of these coming up. But the common location for COC is what really distinguishes it from some of these other things. Management is going to be pretty typical of a cyst. Enucleation, meaning kind of conservative surgical removal of the lesion. All right, so what was the most common location of COCs? If you said anterior maxilla, you're correct. If you said split between the anterior maxilla and mandible, I would also accept that. Slightly more common in the maxilla, though. All right, this one's a fun one. This is our 2/3 tumor, or sometimes this is called a 75% tumor. Some of the numbers are closer to 75%, some are closer to 2/3. And so what do we mean by 2/3? What does it mean that they're follicular? That means it's associated with the crown of an unerupted tooth, kind of like a dentigerous cyst. 2/3 of them occur in the second decade. What age is that? That's the teenage years. 2/3 in the maxilla, or 75%. And most commonly with canines. Did we cover the gender as well? Here it is, 2/3 in female. And so 2/3 or 3/4 tumor, you may hear either. Notice this one tends to occur in the anterior as well, but more common in the maxilla, although it can occur in other places. All right, again, we're talking about benign tumor here, so it should be well-defined, corticated. That's usually the case. And in this lecture, we're talking about lesions that create radiopaque foci. So in about 2/3 of cases, they have radiopacities inside. And that varies, just like I was saying with all these small flakes to small cluster of pebbles. Sometimes they can be totally radiolucent, so keep that in mind. The demographic is a big one for this, so think teenage girl tumor. Nothing about this is very specific. It's about what you would expect from a benign tumor. Can displace teeth, sometimes resorb roots, inhibit eruption. Ooh, do you hear that music? When you hear that sound, you should automatically think the 2/3 tumor, or what I like to call it, the teen girl squad tumor. If you're not familiar with that, look up Homestar Runner, look up Strong Bad. He's the genius creator of the teen girl squad, because that's what I always think of with this tumor. 2/3 in the maxilla, 2/3 in the anterior, 2/3 in females, 2/3 in teen ages. 2/3 have radiopacities in them, associated with impacted teeth, and most of the time that's a canine, but it could occur elsewhere. So here are some examples, just like you would expect. Just looking at this image, could you tell that it's a younger patient? How about right there? Yeah, the mamelons tell you this is a fairly young patient, maybe even in the young teens, maybe a little bit younger, but a nice well-defined, see this well-maintained cortex all the way around it. And then you see these dystrophic, kind of granular ground glass calcifications, or just little flake-like, snow-like calcifications. One of the books talks about it commonly having snow-like calcifications, but it does vary, as you can see. And all of these are right around that canine area. This one happens to be associated with an incisor. But these are just classic examples of what you'd expect to see for the teen girl squad tumor, or the AOT. Too bad it's not considered a cyst, or then it'd be the AOC. All right, like we said, 2/3 in the maxilla. That means 1/3 of them are going to be outside of the maxilla. Here's one associated with a mandibular canine. Doesn't really look like a dentigerous cyst. You would expect it to attach more of the CEJ there. This one also doesn't attach at the CEJ, and we see the small pebble-like calcifications. This one happens to be a premolar, but that is fairly close to the expected location of the canine. All right, differential. As I just showed you with a couple of those cases, look for that attachment to the CEJ. If it looks like a dentigerous cyst, these occur more commonly in the posterior, so that might hint you one way or the other. Of course, remember that nothing's black or white, and they don't always read the book, and so you have to weigh all these different findings against each other. OKC, I said those are so common they can occur anywhere, and a lot of those do occur around the canine. One known variation of the OKC occurs around the maxillary canine, so that's right in that same area. It could occur in a patient as young as you would expect for an AOT. COC, they have common sites. That was the bimodal one, so it can occur in the teenage population as well as older. And so all of these may be on the same differential, especially if it has calcifications, then COC and AOT are going to be on the same differential. Ameloblastic fibro-odontoma, that's more of a pediatric tumor. We'll talk about that in a minute coming up. And then CEOT, I think of as more of an old guy tumor. So older in men, posterior mandible. So maybe they'd be on the same differential, right? These both cause calcifications, but there are also some differences, mainly with the demographics of the patient and the location. Management, nothing unique here. It's well encapsulated, very low recurrence rate. When a surgeon takes these out, they talk about the huge capsule that comes with it, and it all kind of comes out at once. And that's part of why it has such a low recurrence rate. All right, next is the calcifying epithelial odontogenic tumor, or CEOT. In some books, especially older text, you'll see pinboard tumor a lot. I don't use that a lot. The same way I don't lean on Gorlin cyst, eponym. Just like with all of these lesions, this can produce a mineralized substance. Where does this occur? Okay, this is just like kind of your average tumor, your average cyst and tumor, which we said more common in the posterior mandible. What about the age group? About the same as ameloblastoma, so it could occur in fairly young. but average around middle age, a little more common in men. And this is one that can or cannot be associated with an unerupted tooth. That one's about a coin flip. All right, what does it look like? Just what you would expect as far as the margins, although sometimes it might be irregular. And this lying in this lecture, it can cause internal calcifications. What may be somewhat unique to it is these calcifications tend to occur right around the crown of a teeth. So if you see that, that's kind of a classic sign of CEOT. And we'll show you some examples where it has calcifications scattered throughout the lesion, and it almost starts to look like a multilocular appearance. Small loculations, what do we call that when it's small loculations and multilocular? A honeycomb appearance. So you see a couple examples of that. All right, this is one that has more kind of fibro-osseous looking. This is not a fibro-osseous lesion, but the way these calcifications look, it looks kind of granular, just kind of cloudy. Not the best image, right? But these calcifications can vary. They do look like they're somewhat originating around the crown of this tooth. And then this one I like. This is what I was just talking about. This does look multilocular. It looks like you have these small loculations. This is that honeycombed appearance. And if I saw this, I might be worried about hemangioma. Usually they don't grow this big though. But you might have both of those on the differential because of the honeycombed appearance. But this being an older gentleman, posterior mandible, I think first thing that should come to mind probably is CEOT. Here's one where just first glance on this, I might think hemangioma. Right, it's relatively small, it has a honeycombed appearance, but this turned out to be a CEOT. All right, so what do you need to know as far as your differential diagnosis? When you suspect a CEOT, dentigerous cyst, hopefully you know what those look like. Look for the attachment of the CEJ. Obviously those don't have calcifications. Really look for more of the soap bubble appearance for ameloblastoma, although those may be on the same differential if this has that multilocular appearance. Arteriovenous malformations, if you remember back to the macho lecture, the multilocular lecture, this is what I'm referring to when I say hemangioma. So it also shows the honeycomb pattern. In that last case, I probably would have put that first on the differential, and then that turned out to be a CEOT. Adenomatoid, so that's our strong bad tumor, our teen girl squad tumor. Young, location is typically different. This one favors female, whereas CEOT favors males. Ameloblastic fibro-odontoma, that's the next one we're going to get to. Really a pediatric tumor. We'll show you that one coming up. And CEOT, location really, remember bimodal distribution for that one. Age, younger or older. Whereas this one tends to be kind of a wide age range, but starting around middle age, maybe a little before. Management is kind of typical, maybe more aggressive than some of these other weird things we talked about like AOT, but more conservative than ameloblastoma, which we said is locally aggressive and tend to recur. So this is somewhere in between. All right, here we are, the one I kept mentioning as your pediatric tumor. Pedodontists are familiar with this one, and they're first to diagnose it seems like, because it occurs in that age range, 5 to 20. Usually in the posterior mandible, so nothing super unique about that. Usually occlusal to a developing tooth, sometimes right around the alveolar crest. All right, then as far as the imaging features, just like you would expect, well-defined, corticated border, fairly young patient, right? Not super young in this case. They still have a crown of a deciduous tooth here. Third molar is just developing, and this is associated with the crown, but there are calcifications around it. So everything about this looks like dentigerous cyst, and still you see those calcifications. And it being a younger patient, posterior mandible where these tend to occur, you would think ameloblastic fibro-odontoma. Varying amounts of calcifications, just like all of these, they can have pebbles or small, more discrete calcifications. So the calcification always varies. That's kind of a theme that we're seeing here in this lecture. In this case, there's a small calcification, pebble-like calcification. Even though it doesn't look like much of a lesion here, there's just more of a hyperplastic dental follicle, but the calcification in here is what tells you that might be an AFO. It's associated with the crown of this unerupted tooth. It looks like it's delaying the eruption of this tooth. And then this one with just a few scattered flake-like opacities, although I would say internal to here, it looks like there's kind of some scattered wispy calcifications, but younger patient, right? Look at the mixed dentition, if we didn't point that out here. These are all fairly young patients. This one's a little older than the rest of them, with the impacted third molar pressed inferiorly. And so what develops around the crown of the teeth in the posterior mandible in a young patient and creates these snow-like or cloudy calcifications. You would think AFO, maybe this patient's old enough you would start thinking CEOT. Even COC might fit, even though it's not the best location for that. But all of these things are going to be on the same differential, right? And so we need to think of all of these. Think of your CACAO lesions when you see a well-defined lesion with internal calcifications. And then here looks like a sagittal slice, this unerupted tooth. And right along the alveolar crest, we said that's one of the locations for it. You can see these pebble-like calcifications. This to me looks kind of like an odontoma, but guess what? AFO has odontoma in the name, and some people think of those as cousins or even siblings. And so whether this turns out to be an odontoma or ameloblastic fibro-odontoma, I think you're right where you need to be as far as differential diagnosis. All right, and as far as differentiating, your differential diagnosis when you're thinking fibro-odontoma, ameloblastic fibro-odontoma, ameloblastic fibroma just lacks calcification. That's the one I think is definitely a sibling of this, if not maybe the same thing. We just haven't had the calcifications yet. So these you're always going to kind of consider together. If it has the calcifications, go with fibro-odontoma. If not, go with fibroma. Young patients both, usually associated with an unerupted tooth. And then odontoma, I said, look what it has in its name, odontoma. And so maybe these just have a smaller soft tissue component. These may be separate, not really associated with the crown of a tooth. I told you one of those examples to me looked like an odontoma because it looked like little tooth-like structures, whereas ameloblastic fibro-odontoma really has more just kind of small scattered pieces, like we saw granular calcifications or flecks or maybe small pebbles. And management is just conservative, requires enucleation like most benign tumors or cysts. It's rare to recur. Okay, and then remember our CACAO mnemonic, we left out O, which was for osseous dysplasia, because we already covered that. And so this is just a reminder, you've seen this image before, but any lesion left long enough with chronic long-standing inflammation can develop calcifications, even a residual cyst. You've probably seen this for the third time now. And a thought question for you. What's the biggest difference between an AFO and CEOT? Think about that for a second. Okay, so I would say the biggest difference is age, right? AFO is definitely a pediatric tumor between 5 and 20, whereas CEOT is a little bit older. That's the ameloblastoma age, which is kind of an age range, but usually a bit older. And then the second tell, AFO is usually wrapped around the crown of the tooth, while CEOT isn't necessarily. All right, let's put it all together, see how you do with these cases. Take a look at this one. Hopefully you immediately appreciate the well-defined, smooth border. I would call it corticated. Maybe it's variably corticated, but it's definitely a mixed lesion with some internal calcification, right? What's the location? What's the age of the patient? Maybe hard to tell from one radiograph, but they do have nice plump root canals. Looks like a younger patient to me, let's say age 15, with amorphous, dense internal calcifications, relatively large radiolucent rim. Hopefully you're thinking of two things. The first one you might think, oh, is this female or male? You're maybe thinking AOT. What's the second one you should think of? Probably COC. And that's what this ended up being. Remember, COC is the bimodal tumor, or the bimodal cyst, I guess I should call it, where it can occur in teenage patients or older patients and occur in the maxilla or the mandible, slightly more common in the maxilla. So this one really fits for COC. All right, how about this one? If you just see the radiograph, you got to determine everything you can from it. This is an older patient missing some teeth, fixed partial dentures, some resorption here, root canal, fairly thin, small root canals. But there's this impacted lateral incisor, some dystrophic calcifications. Hopefully you can appreciate that. Just these granular calcifications around the crown of a tooth. So now what are we thinking? If your gut instinct was dentigerous cyst, that's not bad, but then you see these calcifications and hopefully you move to this CACAO lecture. And this is another COC. What else would we think? Would we think AOT? Probably a bit old for that one. I don't know if it's male or female. Let's say this is a 60-year-old male. Probably AOT doesn't fit that well. The next thing I might think is CEOT, not the best location for it. But outside of COC, something's got to give from your differential. So nothing else is going to be perfect. All right, you've seen this before, but again, an older patient missing some teeth, fixed denture, well-defined corticated impacted tooth now with these granular calcifications around the crown. Again, it has that AOT strong bad look, but not the right patient demographics. So this is another COC. Just gave you two in a row, the same thing. That was too easy, wasn't it? All right, quick check for you. What do you think of when you see a honeycombed appearance lesion? What's the major thing you remember from the macho lecture? The hemangioma, hopefully? What about from this lecture? What causes that honeycombed appearance? The CEOT was the other one. And you might have an ameloblastoma that has smaller loculations that can look honeycomb. So I think those are the main three I would think of. Ameloblastoma. What was the last one from this lecture? CEOT. All right, that's it. That's CACAO, the calcifying radiolucency, sorted mostly by age and location. That's what really sets them apart. Next topic, we'll move on to radiopaque and mixed lesions without a radiolucent rim and the TOFI differential. See you on that one. Thanks.